be more efficient in handling the hemorrhage and coagulopathy when compared to the blood components. So this is the reason what the literature tells to my knowledge.
Any other question? I have a small question for Dr. Yeah.
Whether the lab value or clinically you are seeing that bleeding is happening, what guides you platelet transfusion in the perioperative period? Okay. Or you give it 1:1:1?
Yeah. So this I will answer what I do. See, the first thing what comes to my mind when I approach a patient who is having a significant bleeding risk, first I have to know the blood volume. Once I calculate the blood volume, then I know anything more than 20% is going to pull the patient into a susceptible and further ongoing bleeding, and also the presence of any cardiac disease. The transfusion triggers differs. When the patient, so the main system what adapts in hypolimic anemia is the cardiovascular system. So when the patient is having a reasonable significant ischemic heart disease, the transfusion trigger should not be the same in a normal patient as in a patient with coronary artery disease. So the existing literature also tells that the comorbid is going to determine the transfusion trigger. So when you have a ischemic heart disease, the trigger should be even more earlier in a higher range. Platelet transfusion, yeah, but see, once it comes into the range of more than 20% blood loss after the initial crystalloid resuscitation, and once you start using allogenic pack cells to resuscitate, and once you resuscitate 4 to 6 pack cells, the need for further ongoing bleeding existence, then you have to go for the ratio. Ratio is 1:1:1. That's what you have to use. So when your hemorrhage is coming to the classified definition of massive hemorrhage, massive transfusion protocol, like 4 pack cells within an hour, then you are into the massive hemorrhage status. Then you have to go for the ratio driven protocol. So once your ratio driven protocol is in the initial resuscitation, then you go for the lab parameters, because lab parameters is going to take time to come. So once the lab parameters come back, then you can change to the cutoff points for the lab parameters. And if you have a point of care TEG, everything available, the TEG gives within the first hour, and the K value will come into display immediately. So you can use, depending on that, you can use the coagulation factors as early in the part of the resuscitation. Hope I answered you.
Can I just add to that? Since I'm doing research on this, on platelet function testing, it's very important for every blood bank today to have a ROTEM or a TEG, as you rightly mentioned. And when you have a ROTEM or a TEG, then doing a platelet mapping with a multiplate or a ROTEM platelet function testing, where within 6 minutes you come to know the area under the curve is diminished, and you don't have to wait for a platelet count to come back from the standard laboratory. And if I know my MS slope and my rate of area is less than 1 ohms, it comes as a graph, a signature graph, which we are all familiar with. I think that's the place where you'll give platelet concentrates, because what's the point of running a blood bank today in 2023 if you don't have a ROTEM or a TEG? Dr. Kundra asked a very pertinent question, because we are still dependent on massive transfusion, despite Raleigh, despite restricted transfusion triggers. But despite so many guidelines coming up, there is a move towards massive blood transfusion again back, and whole blood being given in DIC, but only in those places where there's no ROTEM or no experts to interpret the ROTEM. That's also important. It falls under the banner of a hematologist or a pathologist or a blood bank doing it for you. Why not the anesthetist? I've done it. We've been doing this research for 6 years. It's so easy. It's so simple. You put it in your OR like your ABG machine, and just as we see the basic says in our cardiac surgical patients, see it in our on ROTEM, and you see what you have to give. You don't even sometimes, if your hematocrit is above 35%, you don't even have to give blood to a post-cardiotomy patient. So I personally feel all of us, since we have chapters in our books now on point of care testing and platelet mapping, I think that's the era we are in. We must learn, teach, and interpret ourselves and give the right components. The only bane of this is they are all very expensive. They are all held by just a few vendors, and their marketing in India is very poor. So that's why we are not so well equipped about it. That's what I have a take on it.
Okay. Thank you.
Otherwise, a lovely lecture. I like
Yeah,
your
thank you.
lecture.
One more thing, what we underestimate the use of cryoprecipitates. Fibrinogen deficiency comes early. We are looking about the other clotting factors. Probably we miss fibrinogen cryoprecipitate transfusion, which is rich in fibrinogen. There is another word that literature says. It should be cryoprecipitate should be early in the transfusion approach. Thank you.
Thank you. Thank you, Dr. Venkatesh. We'll call upon the last speaker of this session, Dr. Rakesh Garg, who is going to talk on major trauma management.